now call upon Dr. Elankumaran, Joint Treasurer AIOS, for his talk on Phaco in eyes with compromised corneas. Over to you, Dr. Elan.
Sorry, this is on? Yeah. Thank you, Dr. Vikram. I would like to thank the Scientific Committee Chairman and my teacher, Dr. Namrata Sharma, and my dear friend, Dr. Kudlu, Vikram Jain, and Sachin for this opportunity. Topic for today would be phacoemulsification in compromised cornea. The first thing is, what is a compromised cornea? Simply said, any unhealthy cornea is a compromised cornea, and how do we try to classify it? This is not an absolute classification, but I have tried it for practical purposes. Number one, loss of corneal transparency, where we cannot see through the lens. There's a loss of structural integrity in case of peripheral corneal ulceration. The first one is an opacity, second one peripheral corneal thinning or ulceration, a previously operated eye, or more importantly, an endothelial dysfunction. Along with this, we can add off late what we are facing as a dry eye. So these are the 5 points that I will be covering today. Now, how do we work up these patients? A thorough workup, which would include a dry eye workup, photo for documentation, specular, ASOCT, and then most importantly, something what we miss in all our OPDs is that corneal sensation that needs to be checked. And all these have to be documented not only to educate the patient for follow-up as well as medico-legal reasons. Most important in case of corneal opacity, dry eyes, peripheral corneal thinning would be to get a systemic evaluation and get it cleared by an immunologist. Also, the last but not the least, proper counseling to explain that this is a difficult procedure, need for additional viscoelastics or additional procedures, as well as if something happens, multiple procedures and prognosis. We have to tell the patient that the loss of vision is not just because of cataract, but because of various other reasons. The commonest what we face is dry eye, and I would like to talk first on that particular aspect. Preoperative, intraoperative, and postoperative management is required. Is there any algorithm for that? ASCRS suggested this particular algorithm. It's an idiot-proof, non-invasive, easy to follow. Even a simple optometrist can do it. What it importantly says is, as soon as the patient comes, get his IOL workup done. If by chance you are dilating, taking an NCT, wait for 2 hours and then take this IOL workup. Simplest, they suggested give a questionnaire to the patient. I use a OSDA questionnaire. They suggested the next questionnaire, which I'm going to see. Then you look at these 2 things, the mires on the cornea, and when you're doing the IOL workup, look at the pattern on the cornea, either a topographer, tomographer, or whatever it is. This, if any of these changes between the blinks, that means you're dealing with a dry eye patients. This is the questionnaire they suggested. I use a OSDA questionnaire. It's easier because we were already using that in the practice. And then concentrate on these 2 things. That's what they said, osmolarity and tear film inflammatory mediators. Now, this is practically impossible in any clinical setup. So what do I do is look at the tear film meniscus. All of us know that around 0.1 to 0.25 is normal, but at least we know what is the distance here. So anything less, anything more is always dry eye. And we can look at the meibomian gland. Meibomian gland, we don't need a meibographer. Even a simple AR is enough to look at the meibomian gland, and then go ahead, look for other signs, think whether this is a dry eye, mild, treatable, go ahead with the surgery. How is mild treatable? That's called visually significant, not visually significant. 2 things. If with a blink the patient's vision is changing, that is visually significant. And if the mires are changing or if there is a sign. So if any of these 3 are there, visually significant, first treat this patient for dry eye 2 to 4 weeks. 4 weeks is what is said. I prefer 2 weeks because the patient will run away to the nearest clinic. If none of this is there, simple dry eye is there, go ahead with the surgery and complete it. So first, always treat dry eyes and then go ahead. Now, intraoperatively, reduce all these things. Less drops, less povidone, less paraffin, repeated irrigation and drying. This is something we do. Instead of that, put a blob of viscoelastic and continue. Less time so that there is phototoxicity and less surgical trauma. Don't pull the conjunctiva. Now, no touch methods. Also, there's an incisional damage. So better not completely temporal. We have slightly shifted superior temporal. The treatment I need not have to talk about, all of us know predominantly is artificial tears, but depending on the pathway that is involved, we need to treat it. Shortage of time, each of these is a different, we can talk for 10-12 minutes. Now corneal opacity, how do you manage it? First, look at whether it's a non-active lesion. You cannot operate it in an active lesion. Usual cause is a viral or infection. So these two, it should not be operated. Sometimes it could be a chemical injury or some other thing, and wait for it to resolve and then operate. What is most important? Look for corneal sensation, because if the corneal sensation is less, this will heal very badly. Stabilize the cornea, use lubricants, and then go ahead with the surgery. Intraoperatively, okay, look at the extent of the cornea. If it's something like this, there's no use doing just a cataract. Plan a triple procedure or a combined procedure. If it is something like this, still worthy of trying cataract surgery alone. Now, how do you decide this? These are not my photos from the net, what I've taken. He has classified this into grade 1, grade 2, grade 3. Grade 1 minimal, where there is almost no change, manageable with a toric lens. This can also, grade 2 also manageable with a toric lens. You're getting a regular reflex here, regular astigmatism. Grade 3, this is the place where you go for a combined or a triple procedure. Next, we look at corneal thinning. Very simple. Whichever area there is corneal thinning, do not operate in that particular area. Go to the normal cornea. Preferred is a scleral incision if it is throughout somewhere or it's a systemic problem. Get a immunologist clearance. Again and again, I'm talking about lubricants. Also to that, disease modifiers or steroids need to be added. Now coming to the last part, which is the corneal decompensation. Most important what we face, always whenever I've heard talks on compromised corneas, this is the talk that is concentrated by the speakers, but there are many more, that's why I concentrated there. Simple to note, two things to be done. Specular microscopy, most of us do not have a specular microscopy, so at least do a corneal thickness basically. So what are the criteria that we look at? 1100 is the criteria I look at. Many of them look at 1000, and here I look at 600. What are these readings? If the specular count is less than 1000 or 1100, if the corneal thickness is more than 600, then I'll be thinking of a combined triple procedure for this patient. Triple procedure could be either DSEC, DMEC, or full thickness transplantation along with the cataract surgery. But if it is more than this, first step, I'll always try a cataract surgery. And if at all, if there is a problem, then this is DMEC, this is DSEC, and then you can also do a PK. Off late, we do very less PK because we diagnose these edemas early and then go ahead. I've made it very simplified. Finally, I have a video. If the time permits, I'll play that. Compromised corneas or any cornea that is previously operated. There are two very good talks by Sachin and Dr. Vikram Jain on their topics, but I've kept my topic, which is the transplant. Any case of Phaco in a compromised cornea, use good viscoelastic on the cornea. Soft shell technique, all of us know what this soft shell technique is. Soft shell technique, in the back Phaco, preferable horizontal, not the torsional. Torsional Phaco is preferred over the longitudinal Phaco. Lower the Phaco settings and slow motion. While the surgery has to be done fast, we can spend a little bit time on the Phaco emulsification part. Sorry, that's the video I wanted to play, but I think that will take a lot of time. Let me see whether I can fast forward it. No, it's not able to fast forward. That's almost a 9-minute video. This is what it seems. So, okay, thank you. No, it's still not working, Vicky. Not working, no problem. Thank you. Anyway, these are common things that are shown. Thank you for the opportunity.
Thank you, Dr. Elan.